I want to tell you about Elena. She was 32 years old, healthy, and had not been to the doctor in 2 years. She finally made an appointment for what her insurance portal called a free annual wellness visit. She went in, answered the nurse's questions, and when her doctor asked how she was feeling, she mentioned she had been tired lately, more than usual. That one sentence, "I've been tired," changed the billing code on her visit. What started as a preventative wellness check became a diagnostic evaluation the moment her provider began investigating a symptom. A few weeks later, Elena opened her mailbox and found a bill for $450. She had done everything right. She had insurance. She had scheduled a covered visit. She had shown up. And she still owed $450 for telling her doctor the truth about how she felt.
Elena is not an outlier. Elena is every one of us who has ever left a provider's office feeling like we just walked out of a transaction we didn't fully understand and definitely didn't agree to.
Today, we're going to decode what happened to Elena and what is happening to millions of patients every time we walk into an exam room without understanding the system that we've just entered. This is a special request. Thank you so much for your patience. Longtime viewer and supporter, Shay. So we hope you find this helpful. It answers all your questions, because we know when one person has a question, 1,000 other people have the same question.
So if you're new here, welcome to the Melanin Initiative. I'm Alicia, and I co-host the Melanin Initiative along with Kimberly and Geraldine. Here, we simplify medical information into language you can understand. We create a safe space to ask your questions, and we share our nursing perspective. We're a health literacy podcast. When we say health literacy, we're talking about your ability to obtain information, to understand that information, and to use that information to manage your health and advocate for others. Our mission is twofold. One, to simplify complex health information, and two, to elevate the expertise of nurses, spotlight the diverse career opportunities within the healthcare industry, and inform our peers how to leverage their expertise as clinicians and entrepreneurs. If you haven't already, subscribe on Apple Podcasts or Spotify and leave us a 5-star review. Thumbs up the video, leave a comment, and share the show with your friends. This shows the algorithm that this content is important. So when people like you look for information like this, we'll show up higher in the search results. And as a reminder, this show is for educational purposes only. The opinions expressed are our opinions alone. They are not a representation of any of our affiliations. If you are experiencing a medical emergency, you should seek medical attention and medical guidance from your healthcare provider. If you're having a physical emergency, you can call 911. And if you're having a mental health emergency, or if you know someone who is, you can call 988 or text 741-741. Handing it over to you, Kimberly.
Thanks, Alicia. So let's define what we're actually talking about today: medical billing. This is the process by which healthcare providers translate clinical services into standardized codes, numbers, and submit those numbers to insurance companies or patients for payment. It sits at the intersection of clinical documentation, administrative policy, and financial law. And most patients and many clinicians navigate it without ever being taught how it actually works. The scope of this problem is not small. According to the Consumer Financial Protection Bureau, medical debt is the most common form of debt in collections in the United States, affecting up to an estimated 100 million Americans. 1 in 5 insured adults reports receiving a surprise medical bill, meaning a bill they did not expect for a service they believed was covered. And research published in Health Affairs found that billing errors affect an estimated 80% of medical bills in some form, ranging from duplicated charges to incorrect coding to services billed that were never rendered.
Wow, that hits home. And I'll share my story a little later, but those numbers do not land equally across communities.
They don't, particularly when we look at our Black and Latino patients, who are significantly more likely to be uninsured or underinsured, to receive care in hospital outpatient settings where facility fees apply, and to carry medical debt that goes into collections. A study published in JAMA found that Black patients were more likely to be balance billed and less likely to successfully dispute those charges. For patients for whom English is not a first language, the billing process presents an additional barrier. those consent forms, explanation of benefit documentation, and dispute processes are rarely available in languages other than English, which creates a compounding disadvantage. Who carries the heaviest burden in the system? Our older adults, who we are recognizing this month. May is Older Adult Awareness Month. So we have a whole series of episodes this month dedicated to our most precious community, our fastest growing age segment of the population. Those adults 65 and older will soon, very soon, be the largest segment of our population. And so if you haven't already, we invite you to check out episodes that we've done dedicated to our older adults on sleep, non-pharmacological pain. We're doing this medical billing one. We're going to cover insurance as well. Now, our older adults managing multiple chronic conditions, which happens as we get older, depending on how we take care of ourselves, who interact with both Medicare and supplemental insurance simultaneously. Now, veterans navigating the intersection of VA coverage and private insurance. Our pediatric patients are uninsured or underinsured and absorb full cost exposure. And then, of course, our deaf and blind patients, who are often not part of the conversation, face an additional barrier accessing billing information and dispute processes that are not designated for accessibility. Then when we look at our LGBTQ plus IA patients who face discriminatory billing practices and coverage denials at higher rates, particularly for gender-affirming care. And then patients for whom English is not a first language are disproportionately subject to billing errors that they cannot identify or even dispute.
And this is not a system that fails by accident. It is a system that was built in a particular direction, and understanding how it was built is the first step to navigating it with your money and your dignity intact. So let's dive in. Let's get into the mechanics. Every medical bill is built on two foundational code sets. The first is the CPT code, which is the current procedural terminology. This is a 5-digit code that tells the insurance company what the provider did. A standard office visit for an established patient the code is 99213. A more complex visit is 99214 or 99215. An EKG is 93000. Basically, these codes probably don't mean much to you, but it means a lot to your providers billing your insurance companies. These codes are managed by the American Medical Association, and they are public, which is why we're sharing this. These are numbers that you can look up. The second code is the ICD-10 code. The ICD stands for the International Classification of Diseases. This code tells the insurance company why the services were performed. E11.9 is type 2 diabetes without complications. I10 is an essential hypertension. The CPT and ICD-10 codes must match, meaning the service performed must be medically justified by the diagnosis that is documented. If they don't align, then the claim is denied.
This is so complex. And here's where Elena's story becomes a billing story. So when Elena mentioned fatigue or being tired, her provider was now obligated to investigate a symptom. That changed the ICD-10 code from a wellness visit to a diagnostic evaluation. The CPT code changes, the billing changes, and Elena had no idea any of this was happening while she was sitting on an exam table.
And for our nurses and nurse practitioners, this is a documentation conversation as much as a billing conversation. And I'm sorry to say, you don't get a lot of it in our training. It's kind of something you figure out on your own and with the help of your colleagues if they're available. Now, your clinical notes drive and this explains why we have those medical billing errors that we talked about at the start of the show, okay? And that's why we're having this conversation with you, because we're on the same team. When both of us are speaking the same language, we get better outcomes. Now, your clinical notes drive the codes. That's where we spend all of our time. That's what we get paid for, the documentation, not the care of the patient. The codes drive the reimbursement. This is how much they get paid back after insurance takes their portion. Now, for clinicians who are employed, this connects directly to your RVUs. This is your relative value units. Think of an RVU as a productivity point that Medicare assigns to every CPT code. A simple level 3 visit carries approximately 0.97 RVUs. A complex level 5 visit carries approximately 2.8. If your contract pays $45 per RVU, the difference between documenting a level 3 and a level 5 correctly is the difference between $43 and $126 for the same hour of your time.
And downcoding, which is when a payer reduces the complexity level of a visit because the documentation doesn't fully support the higher code, cost the clinician and practices significant revenue every year. For the patient, downcoding means the price of what felt like the same office visit fluctuates in ways they cannot explain or predict. For our NP entrepreneurs, your front desk team, your billing team, and your clinical documentation are all part of the same revenue cycle. A provider who delivers a level 5 visit but documents a level 3 is leaving real money on the table every single day. And I will say in my primary care practice experience, that was a huge thing. They were always saying, oh, you did this, you have to make sure you add that code. Even if you had a conversation with a patient about something totally unrelated to what they initially came in for, if you gave them advice or if you gave them anything, you have to add that code to like increase the level of the visit. So this is not necessarily upcoding because this is actually things that you've done in the visit. This is learning to document the complexity that you are actually managing. For patients and caregivers, you have the right to ask for the CPT codes before your visit and after. You can look up what those codes mean. If your bill does not match what you were told, that is a disputable charge. Be sure to write it down. Call the billing department, ask for an itemized bill. You are legally entitled to one. And for older adults managing Medicare, your explanation of benefits document, which is called an EOB, is not a bill. It is a record of what was billed, what Medicare paid, and what you may owe. Read it line by line. Billing errors in Medicare claims are common and frequently go unchallenged because patients do not know that they can dispute them. And I'm one of those patients. I did not know that you can dispute certain charges.
And I also want to point out, it's not just for Medicare patients. I actually just got one of these explanation of benefits for my dentist visit not too long ago. And I was reading it and it was like, patient owes $22. And I said, what? So it's definitely something that you want to pay attention to and read. And if you don't understand it, ask for help. So our key takeaways from this section is a medical bill is a document you are allowed to question, dispute, and negotiate. You do not owe what is on the paper until you have confirmed it is accurate. Ask for the codes, ask for the itemized bill, and ask why. Be your advocate.
I wish I had been my own advocate. You guys are aware, but I had like a neurosurgery a couple of years ago. And although insurance obviously covered a large percentage of it, I would get during my recovery or even up to like after my recovery and months later, I would get these bills from that surgery. And there was one bill in particular that my insurance would not cover because it was some device that was used in the operating room that the insurance didn't cover, but I'm on the operating table. So it's not like I can refuse, like say, hey, don't use that device. So they obviously used it. And they, later on the insurance denied because it wasn't in their, whatever they would cover. So I got the bill, which was a couple $1,000s. And at the time I didn't know. So when the more you know, I just paid it because I was like, all right, this is part of like my out-of-pocket cost that I have to cover. My insurance is not covering this, so I have to cover it. And I spoke to a colleague after the fact. She said, you should have disputed it, or you should have contacted the hospital, or you should have, like, there's ways, that you could have either gotten it reduced or not paid for it at all, because it's something that you didn't know that you were going to be charged for. And it was a significant amount of money. So always ask questions. I'm not saying to dispute everything, but, always ask questions, and definitely contact the doctor's office or wherever you're getting your services for to question everything.
I wonder how much that surgeon knows too, like about how it actually lands on the patient side,
right.
Though.
Yeah.
Yeah.
It was a surprise bill. And I was like, the medical debt was a real thing, because although I had insurance, it was like I was getting all of these bills back to back to back. And it was becoming overwhelming because I'm like, what is and don't get me wrong, insurance covered a great deal, but you still have that out-of-pocket max and that deductible that you have to reach, which I had, which was why it was confusing that I was getting all these extra bills, but besides the point. But to understand, so moving along, the system behind the system. So to understand why this billing system produces the outcomes it does for our communities, we have to go back to 1910. The Flexner report, funded by Rockefeller Wealth, triggered the closure of nearly half of all medical schools in the United States, specifically targeting institutions that served the working class and Black communities. We lost Flint Medical College, Knoxville Medical College, Louisville National Medical College, Chattanooga National Medical College, and Leonard Medical School at Shaw University, among others.
And we need to say their names and sit with what their closure meant. Researchers have estimated that if these schools had remained open, we would have tens of thousands more Black physicians practicing today. That deficit has a direct line to maternal mortality rates, to infant mortality rates, to the documented survival advantage Black infants have when cared for by Black providers, and the absence of community-based clinicians who understood the social determinants of health their patients were actually living with.
Yeah, all those schools that she named are all Black medical colleges that closed down when the Flexner report was released, which is a guy went over to Germany. He brought over their medical-based system, which is the one that we practice in today, the one that you're experiencing. And they set a new standard on what needs to be taught in medical schools. And those Black schools did not meet the standard. And so not only did all those schools shut down, obviously we lost a significant pipeline to how we get Black doctors today. And that disparity continues to show up, not only in the care and who's providing that care, but in our medical education system. So the Flexner report did not just change which schools existed, it changed the entire model of medicine in our country, from a community-rooted, relationship-based practice toward a procedure-driven, institution-centered system. That shift is the origin of billing infrastructure we're talking about. When healthcare became centralized in hospitals, right? There was a time where going to the hospital was your last resort, where being at home was the most preferred. Then they started making a fear of home-based care, which still shows up today, especially when we start talking about maternal health and whether you should actually have your birth at home or versus the hospital. You see that conversation come up. So when healthcare became centralized in hospitals and elite academic institutions, it also became commodified. The cost center model, where hospitals prioritize high margin procedures over long-term chronic disease management. And it's a direct descendant of that 1910 restructuring. For NP entrepreneurs, this history is not background. It is the reason our communities are more likely to present to the emergency department for conditions that should have been managed by our friends in primary care. It is the reason facility fees exist and disproportionately affect our patients. It is the reason building community-based, accessible, culturally aware practices is not just a business strategy, it's a structural correction. And the data shows that NPs and PAs are more likely to work in communities of color, to work in rural environments than our physician colleagues. Now, that's just the data. That's not my opinion, okay? Now, for our vulnerable populations, when we talk about our veterans specifically, the VA system was built as a parallel health infrastructure precisely because the dominant system failed to serve those who had served our country. Understanding how VA billing intersects with private insurance is a distinct and important layer of the conversation we're having today, and one we will return to in a future episode. For LGBT plus QIA patients and clinicians, we always forget that there's clinicians that need to be part of this conversation too. They're also not really ever given a platform when we're talking about this community. Discriminatory billing and coverage denials for gender affirming care are documented and ongoing harm that sits directly within the structural legacy. Providers who affirm their LGBTQIA plus patients in clinical documentation and billing practices are doing work that is both clinically and ethically necessary.
So the system was built to serve a narrow population. Understanding that does not mean accepting it. It means knowing where the leverage points are and using them.
So our takeaway from this section, what you're going to share with your friends and family after watching this, is the billing system is not a neutral administrative process. It is a structure with a history, and everything and everyone has an agenda. Knowing that history changes how you navigate as a patient, as a clinician, and as a business owner.
All righty, so we're going to switch gears a little bit, and here we go. Here's something most patients do not know before they walk into a building. Where you receive care determines what you are billed, sometimes by hundreds of dollars for the exact same service. And oh my gosh, I'm going to deviate for a second. I have a personal story related to this. So I was having some gastrointestinal issues in my life, and I was like, hey, I need to get this figured out. So my provider suggested that I get a colonoscopy. Now, I'm a younger individual, so typically, for someone my age, a colonoscopy isn't really, the first line of defense. But being a healthcare provider, I was like, y'all go give me a colonoscopy. Nonetheless, so I had my colonoscopy. It was scheduled. I consider myself a pretty health literate individual. I work in healthcare. I work for a large health system. And I have I'd say decent insurance. So I figured, I could navigate this pretty easily. So my copay for the procedure was $400. I knew that going into it, paid that, got my procedure done. And then I got a separate bill afterwards that had this resort fee on it. And I was like, I'm sorry, what? And the resort fee was more than the copay. And I'm like, what does this mean? And it was directly related to the building that I chose, that was recommended to get the colonoscopy in. And then also the person that did the procedure also billed me separately as well. So like I got a bill from the person who did the colonoscopy. I got a resort fee, and that's on top of the copay. And I just could not believe that I had to put out of pocket over $1,000 for a colonoscopy. So this conversation is very prudent to my heart, because I could not believe someone who navigates healthcare every day got swindled like this. But anyway, so in a private clinic or independent practice, an NP or PA can bill under a physician's name. This is called incident to billing and receive 100% of the Medicare reimbursement rate, but only if the supervising physician is physically present in the office suite at the time of the service, not in the room, in the building.
And in a hospital outpatient department, incident to billing does not apply. The NP bills under their own name and the reimbursement rates drops to 85%. For practice owners, this difference in reimbursement structure sometimes results in physicians being required to be physically present in a building, not to provide care, but to protect a building rate. That is structural inefficiency that costs practices real money and has nothing to do with clinical quality. For patients, the more immediately felt consequence is the facility fee, which is what Alicia brought up, sometimes called the hospital tax or the resort fee, which was new. I'm like, are we on vacation? But anyway, right. When you receive care in a hospital-based outpatient setting, you may receive two separate bills, one professional fee for the clinician and one facility fee simply for using the space. A lab draw costs $80 in an independent clinic. A lab draw that costs $80 in an independent clinic can actually cost $400 or more in a hospital outpatient department for this reason alone. Before your next appointment, ask, is this location hospital-based? That one question can change your out-of-pocket costs significantly.
I wish I had the Melanin Initiative before I had my colonoscopy.
Yeah, and those reimbursement rates that they're talking about, it's just saying that when a doctor sees you, they get more money back. When the NP or PA sees you, we get paid less. That's what it's showing you. But if we bill under that doctor, so I'm one of those NPs, I don't bill under a physician, I bill under my own name. So I'm getting that 85% reimbursement. Now that doesn't, now the NP, who's the nurse who's going back to NP school, or the NP that's working, that they don't know what that even means. They don't know what that means. They just assume that they were going to get paid a lot of money and that they were going to be able to understand how to manage that money. That's a conversation for another day. That's financial literacy, something else we're not taught. So that's what that means, that if you bill under the physician, you'll get the 100%. So in states like Texas, where I reside, that's a requirement that you have a physician there. Now, what Geraldine said is that they have to be in the building, but they're not taking care of patients. They're only there to get that 100% reimbursement. And this is a dialogue that we have all the time in medicine about whether that's really necessary. And in some cases that have been brought to court, they were supposed to be in the building and they weren't. And there's a lot of cases for my NP and PA friends that have told me that they work under a doctor. They're billing like they're supposed to. And the doctor who never walks foot in that building goes behind them in their billing, and they change the billing so that they get paid. And those NP and PAs have left those practices. Because that's a lack of trust there. That's betrayal. That's deception. Another conversation for another day. So that's why this conversation is so important, because we don't talk about this in school and we don't talk about it at conference, but it's happening in real life. And so you go through all that hard work, all those years of dedication to end up in a place where you don't understand what's going on and what your options are. So this is also where the No Surprises Act becomes relevant. Since January of 2022, patients are protected from surprise out-of-network billing when they receive care at an in-network facility from a provider they didn't select. So let's say you have an anesthesiologist on your case, radiologist, or an emergency physician or NP. If you receive a balance bill in this situation, it's illegal. You can respond in writing under the No Surprises Act. I'm requesting that this claim be reprocessed at my in-network rate. You also have the right to request a good faith estimate. This is a written cost estimate before non-emergency services from a provider you contact for care. So what that means is that sometimes you pick a hospital because it's in network, but the person who actually cares for you might not be in network. So your insurance paid the portion for the hospital, but no coverage for that physician or MPPA who wasn't covered. That's where you get the other bill. That's what that all means. Now, for our deaf and blind patients, the dispute and appeal process for surprise billing are not uniformly accessible. If you or someone you support needs accommodation to navigate a billing dispute, you can request accessible formats and communication support. That request is protected under the Americans with Disabilities Act, Section 504 of the Rehabilitation Act. For those of you who, or if you know someone whom English is not a first language, you have the right to request a translated explanation of benefits, that's what Alicia was talking about, and billing documentation. This right is not always volunteered because people are busy. That's why you have to be empowered and ask for the care you want and the care you need, and it's worth your time.
Absolutely. And for those who have decided to step outside the insurance system entirely, the self-pay or cash pay rate is frequently lower than the insurance negotiated rate for many services. This is counterintuitive, but documented. Always ask what the cash pay rate is before you assume insurance is your best option for a given service. I will say kind of related, unrelated, but a lot of people are experiencing a lot of this with GLP-1s and medications lately. You could pay out of pocket cheaper for these things rather than going through your insurance where it could be thousands of dollars. So it's always interesting.
Yeah, even for prescription meds, like working in like the primary care setting, a lot of times, sometimes I would like always recommend GoodRx to a lot of patients because their insurance will charge them more for a medication. And if they use GoodRx, which gives like offers of coupons, they can get the medication significantly cheaper. So there are like definitely ways around like paying a bunch of money for meds.
Yeah, and GoodRx, and Mark Cuban has his Cost Plus Drugs. That's another one. Let's talk more about this cash pay system. Oh, that's what it was. We talked about the Flexner report, how it changed our medical system, and in order to promote this movement of it being more medically based medications and surgeries, and also more based on the fear of outside of the hospital. You cannot get care out the hospital. That's
Right.
dangerous, and you can't rely on plants. That's dangerous, right? They were killing thousands of women who were healing their community using plant medicine, the oldest and still most widely used form of medicine. It was because they were healing people. They said, "Oh, you're witches." So they killed thousands of women. And so for years, it was hidden. Then they started to resurface. But that's why here, it's not even recognized as a clinical practice like it is over in Europe, where they actually have a medical license number. And that speaks to the business portion of our medical system here in America. And so, again, there's a fear that you have to have insurance. You have to have insurance. It's going to help you, as opposed to this NP who just started their own wellness practice and who's offering you transparent pricing. This is the price. It won't change after this. You give me $200 today, you'll get no other bill until you come back. They're putting fear over that because they want you to use the insurance. And people, even when we start your own business, you'll be like, well, I'm going to hold on to that. We all have worked with nurses who have their own business. And the only reason they're working with us is to hold on to that good insurance. There's a fear that if I walk away from this job, I won't have good insurance. We just explained it's cheaper. It's completely cheaper. And that's why you're going to see more NPs and physicians and PAs who can have their own practice moving towards what we call direct primary care. This is where you pay a flat monthly membership directly to a practice and you bypass insurance for primary care services. It's a direct response to the structural complexity we've been talking about. It removes that prior authorization. I have my own story. I've been waiting for 3 months for an inhaler that I've been taking for over 10 years because of prior authorization. Reduces administrative overhead and allows clinicians to spend time with patients rather than fighting claims. For communities that we serve, particularly older adults managing multiple chronic conditions, our veterans and patients with complex care needs, this whole DPC, direct patient care model, and dentists are doing it too, can mean the difference between 10-minute visits and 60-minute visits because insurance, because it's a numbers game, right? If I can get you to get a visit done in 10 minutes, you can see 6 people in an hour. I mean, I'm going to get paid 6 times more. But if you spin it, and so I can't answer your questions, I can't explain what this medicine does, I can barely hear what you have to say. And I'm not going to talk to you about when Alicia keeps saying, and no one ever tells you. because I only have 10 minutes.
Right.
And you spent 5 of that minutes telling me why you were upset you waited in the waiting room. So now
Right.
the visit's halfway over, right?
Right.
So, but that NP who's starting their own wellness practice, their own med spa, whatever they're building, they can spend a whole hour with you. And you paid a monthly membership and you get multiple access points. That 10-minute visit, you can't even do that again for another 12 months.
Right.
Okay. It's not the right model for every patient, right? And one's not better than the other. We're teaching you the whole approach because I believe in both of them, right? There's a pastor who says he believes in prayer and prescription. He believes in therapy and worship, like two things can exist at the same time. But it's worth understanding your options. And we hope that you're feeling like you're starting to understand that today. And not just you patients, because we're patients too.
Right.
Even as clinicians, we're not taught this. We're just not taught it. And it helps the system run. It helps the system stay in place when few people understand how it works.
Right. Know the signs of a stroke because the faster you act, the more of the brain you save. Use the word fast. F for face. Ask the person to smile. Is one side drooping? A for arms. Ask them to raise both arms. Does one drift down? S, speech. Ask them to repeat a simple phrase. Is their speech slurred or strange? T, time. If you see any of these signs, call 911 immediately. Do not drive yourself. Do not wait to see if it gets better. Time is brain. Every minute counts. Other signs of stroke include a sudden severe headache with no known cause, sudden vision changes in one or both eyes, sudden confusion, and sudden loss of balance or coordination. Stroke can happen at any age. Black Americans experience stroke at nearly twice the rate of white Americans and are more likely to die from it. Know the signs, share them with your family, put FAST in your phone right now so you never have to remember it in an emergency. If you or someone near you is showing signs of a stroke, call 911. Not in 5 minutes, but now. This message is brought to you by the Melanin Initiative podcast, where we simplify health information so you can advocate for yourself and the people you love. Find us on Apple and Spotify. So the key takeaway here is know the setting before you walk in. Ask if the facility is hospital-based. Ask for a good faith estimate, which I'll be sure to do from now on. Ask for the cash pay rate. These are 3 questions that can save you hundreds of dollars and thousands in my case, and change the terms of your care before you ever sit in the exam chair.
And this leads to stress. That goes back to our episode on sleep, which if you are having all this debt and it's causing you a lot of stress, you're not sleeping. If you haven't watched that episode, we invite you to go check it out. And if you're having trouble sleeping because you have sleep apnea, you can check out that episode too. That is still to date one of our most popular episodes. Now, before we get back to our friend Elena, let me give you your homework. Okay. What we're doing here is we're doing what we call action-based. And that's kind of a thing that's really, I think, unique in nursing. People always ask what's the difference between nurses and doctors. And the more I do that, the more I get asked that question, the more I'm trying to find answers for it. Because the nurse is the one actually delivering the care. Okay. I write orders, I give recommendations, but I'm not the one delivering the care. The nurse is the one who is doing that. They have the most data. They are the master of communication, the master of human behavior. They understand who's lying and who's telling the truth. They know who's really in pain, whose partner is in another hospital and having their own cancer treatment, right? They have all the information. So it's the nurse who knows this information. So we're giving you action because that's what the nurse does. We need you to get up. We need you to take this pill. We need you to sign this consent form. We need you to repeat back what I just said. And we need you to not come back. So the nurse is all about action. I think that's a really big difference because even as a provider, I'm not doing that. And now I do it because I'm a nurse.
For you, yeah.
I love this, but it's very easy for me to just walk out. If I have a lot of people to see that day, it's very easy for me to just walk out. And if the patients give me a lot of pushback, I just walk out.
Easier.
I just leave. But now, because I'm trying to get sleep too. I'm trying to get better sleep too and not be stressed out. Now, before we get back to Elena, let's talk about your homework, which I give my patients every day. And they look at me and say, my job? Yes, we're a team. We can only go where you take us. It's actually all about you. And just like financial literacy, where you're given all this responsibility, like you're sending all your kids to medical school and nursing school, assuming that they're going to make a good amount of money, they're going to know how to manage it. That's not true. People have lots of money and they still don't know. They can still be living paycheck to paycheck. They can still have this medical debt. Just like our patients, just because they're diagnosed with diabetes, heart failure, liver failure, Doesn't mean they know how to manage it. That's why this show exists, for that very reason. So if you're a patient or a caregiver, we want you to request an itemized bill for every healthcare encounter. Look up that CPT code on your explanation of benefits. If anything doesn't match what you received, call the billing department. It's going to take more than one call, and dispute in writing. Use the fairhealthconsumer.org to price check any procedure before you pay. You can only do this if you've been going to primary care, your naturopathic provider, integrative medicine. You can't do this in an emergency. It's
Right.
probably not gonna have any time. That's why we emphasize primary care, so you can get ahead of it. You can't get ahead of everything, but you can get ahead of a lot of things. And ask every time whether the facility is hospital-based and what and that resort fee. I would really be curious if the person on the other side knows that exists. Now, the clinician, I'm gonna say no, but the billing person they pay, oh, they're worth the money. If they know about that code, they're worth the money. Okay.
Yeah.
That's what I learned when you were talking about that. I was like, oh, that's who you really need on your team in the back office. Now, if you're a nurse and that's not a sexy job. How many kids are being told to do that?
Right.
Right. You're not even thinking about that. Now, if you're a nurse or a nurse practitioner, your clinical documentation is your billing. You're getting hired to document. You're not getting hired to take care of patients, because when you document, that business gets paid. You're being hired to grow the business. And I say, whether you own a business or you work for someone who owns a business, we're all in business. But if you don't talk business, you're leaving money on the table. And what's rule number 1, Alicia? We don't leave money on the table.
Never leave money on the table.
And rule number 2,
don't forget rule number 1.
Okay. So document the complexity. When we talk about smoking cessation, nutrition, we get billed, we get paid for that. Okay. Now, document the complexity you're actually managing. If you are employed, understand your RVU contract, know what you are being paid for per RVU, what the benchmarks are for your specialty, and whether your documentation is supporting the level of complexity you're delivering. The AAPC and the MGMA are your resources. Use them. They'll be in the description box. If you're an entrepreneur, cosmetic and ped, audit your billing workflow this quarter. Are your codes matched correctly? Is your front desk trained to inform patients about facility fees, like that resort fee, and cost estimates before the visit? We're telling patients to ask these questions. Is your staff prepared to answer them? Are your providers credentialed correctly? Compliance is not a legal protection. It's how you build a practice your community can trust and afford, because we're here to talk about the money.
The money. So let's get back to Elena. After she received that $450 bill, she did not pay it immediately. She called the billing department and asked for an itemized statement. She went to the fairhealthconsumer.org, looked up the CPT codes that were on her bill, and she found that one charge did not match the service she had received. She disputed it in writing, referencing the specific code and the date of service. The charge was removed. Her final bill was $180. She paid it. And she has never walked into a medical appointment since without asking upfront what codes will be used and whether any portion of the visit could change her billing status. Nobody coached Elena through a complicated process. She learned the language, and once she knew the language, she could advocate for herself.
This is what health literacy actually looks like in practice. It is not just understanding your diagnosis. It is understanding the system that surrounds your diagnosis and knowing you have the right to push back. The more you know.
Yeah, and I think this speaks to the fact that we're trained to see that, we're supporting the patient. It's their decision. But the impression I have from patients is they don't realize how much they're in control. And that's what I think this conversation puts it back in your lap. Here's the information. You have to use it. Okay. And hopefully you feel empowered to do that and share it with your community. I never want you to just take it for yourself. Say, oh, it doesn't apply to me. If you see 10 people today, tell 10 people. And my hope is that they tell 10 people and they tell 10 people and things get better. Now, today we covered CPT and your ICD codes. And if you're applying for your first job as an NP or a PA, don't assume that company is going to teach you all of this. It's just not part of what they need to do. They have their own mission and vision, and that's what they're going to do. This part is actually, so just like we're telling the patient their job, this is your job. When you get off work, this is what you have to look up. This is what you have to learn. So you can't pack your schedule with multiple jobs, the full-time job, the PRN job, the teaching over here, the clinical instructor over there. You got to say no. You got to have time. So you can also get that sleep. Now, RVUs and downcoding, the Flexner report, that's available on the internet. You can look that up. It's a huge document. And its structural legacy, the difference between private clinic and hospital-based billing, our Incident 2 rules, the facility and resort fees, and the No Surprise Act, and of course, the direct primary care, and your rights as a patient in every one of those contexts. The resources we referenced today will be on our screenshots and also in the description box.
All righty. So if this episode gave you something, share it. Someone in your circle has been sitting on a medical bill they do not understand and have not disputed. Send them this episode. Find us on Apple Podcasts and Spotify. Leave us a review and tell us what topics you want us to cover next. This episode exists because of this community. If you are a nurse practitioner who wants to go deeper on the business and clinical side of healthcare entrepreneurship, visit Mahogany Dermatology Nursing and the Alliance of Cosmetic Nurse Practitioners. Links are in the show notes. If you found this information helpful, check out our episodes on insurance.
Thank you all for watching. We'll see you next time.